Welcome to the MRCPology channel for a quick review, understanding, and revision of the topic. Imagine a slim, middle-aged patient who develops diabetes but has no typical features of metabolic syndrome. They also report gradually worsening hearing, and several relatives on their mother's side have similar problems. This combination should immediately raise the possibility of maternally inherited diabetes and deafness, usually abbreviated to MIDD. MIDD is a mitochondrial disorder characterized by diabetes mellitus and progressive sensorineural hearing loss. The most common genetic abnormality is the M.324.3A to G mutation in mitochondrial DNA. To understand MID clearly, think in four connected areas: inheritance, impaired energy production, the clinical pattern, and management. First, consider the inheritance. Mitochondria are inherited almost entirely from the oocyte. This means mitochondrial disorders follow a maternal pattern of inheritance. An affected mother may transmit the mitochondrial mutation to all her children, whereas an affected father does not usually transmit it to his children. However, carrying the mutation does not mean that every family member will have exactly the same clinical features or disease severity. This variation is explained by heteroplasmy. Heteroplasmy means that each cell contains a mixture of normal mitochondrial DNA and mutated mitochondrial DNA. Different tissues and different individuals within the same family may carry different proportions of the mutation. Disease develops when the proportion of abnormal mitochondria exceeds the functional threshold of a particular tissue. This is known as the threshold effect. If you remember one thing about the inheritance, remember this. Diabetes and deafness passing through the maternal side of a family strongly suggest a mitochondrial disorder. Now let us connect the genetic mutation to the pathophysiology. The mitochondrial DNA mutation impairs oxidative phosphorylation. Impaired oxidative phosphorylation reduces ATP generation, particularly in tissues with high energy requirements. The pancreatic beta cells and the cochlear hair cells are especially vulnerable. Both require a reliable supply of mitochondrial energy, both have relatively limited protection against oxidative injury, and both may be affected when the mutant mitochondrial load exceeds their functional threshold. This explains why the characteristic combination is diabetes plus sensorineural hearing loss. However, mitochondria are present throughout the body, so a MIDD can also affect skeletal muscle, the heart, the kidneys, the eyes, and the gastrointestinal system. Let us now focus on the pancreatic beta cell. Under normal conditions, glucose enters the beta cell and undergoes glycolysis and metabolism through the tricarboxylic acid cycle. This increases mitochondrial ATP production. The rise in the ATP to ADP ratio closes ATP-sensitive potassium channels, also called KATP channels. Potassium can no longer leave the cell as freely, so the beta cell membrane depolarizes. Depolarization opens voltage-gated calcium channels. Calcium enters the cell, and this calcium signal triggers insulin release. So the normal sequence is glucose metabolism, increased ATP, closure of KATP channels, membrane depolarization, calcium influx, and insulin secretion. In MIDD, the mitochondrial mutation disrupts the sequence at the ATP generating stage. Glucose enters the beta cell, but mitochondrial ATP production does not rise adequately. The ATP to ADP ratio therefore increases less than it should. The KATP channels do not close effectively. Membrane depolarization is reduced, calcium influx is impaired, and less insulin is released. The key mechanism is therefore defective glucose-stimulated insulin secretion caused by insufficient mitochondrial ATP production. Over time, progressive beta cell dysfunction produces increasingly insulin-deficient diabetes. This is why the condition may initially be mistaken for type 2 diabetes, but later behaves more like an insulin-deficient state. Now consider the hearing loss. Cochlear hair cells have a very high energy demand. Their function depends on continuous mitochondrial ATP production to maintain ionic gradients and transmit auditory signals. Mitochondrial dysfunction causes progressive metabolic stress and cellular injury within the cochlea. As the hair cells become damaged, the patient develops bilateral sensorineural hearing loss. The hearing impairment is usually progressive and may appear before the diabetes, at the same time as the diabetes, or occasionally after it. MRCP trap. Do not assume that hearing loss in a patient with diabetes is simply age-related. In a relatively young, non-obese patient, especially with a maternal family history, progressive bilateral sensorineural deafness is an important diagnostic clue. Let us now put the clinical features together. MIDD usually presents in young to middle adulthood. The patient is often non-obese and may not have the insulin resistance, hypertension, dyslipidemia, or central obesity expected in conventional type 2 diabetes. The diabetes is mainly caused by impaired insulin secretion. It may initially be controlled without insulin, but beta cell function often declines progressively, and many patients eventually require insulin treatment. The second major feature is progressive bilateral sensorineural hearing loss. In many patients, the hearing loss precedes or accompanies the diagnosis of diabetes. Other mitochondrial manifestations may provide additional clues. Skeletal muscle involvement can cause myopathy, muscle weakness, or exercise intolerance because the muscles cannot generate energy efficiently during exertion. Cardiac involvement may produce cardiomyopathy or conduction disease. This matters clinically because conduction abnormalities can be silent until they become significant. Renal involvement may cause impaired renal function or albuminuria. Ocular involvement may produce macular dystrophy. Gastrointestinal involvement may cause dysmotility, and some patients have short stature. Not every patient will have all these features. The variable presentation reflects heteroplasmy and the different mutant load within different tissues. Do not confuse MIDD with type 1 diabetes simply because the patient is young or insulin deficient. Type 1 diabetes is usually autoimmune and is not characteristically associated with maternally inherited deafness. Do not confuse it with ordinary type 2 diabetes simply because the patient presents in adulthood. The absence of obesity, the presence of hearing loss, and the maternal family pattern should prompt reconsideration of the diagnosis. The three key diagnostic clues are diabetes, sensorineural deafness, and a maternal family history. Confirmation is obtained through mitochondrial DNA testing, particularly testing for the M.324.3A to G mutation. An important practical point is that the mutant mitochondrial load in blood leukocytes may decline with age. Therefore, a negative blood test does not always completely exclude the diagnosis when the clinical suspicion is strong. Urine epithelial cells may contain a higher detectable mutant load and can therefore provide a better diagnostic yield than blood in some patients. The key clue is a convincing clinical phenotype with an apparently negative blood test should prompt consideration of testing another appropriate tissue, particularly urine epithelial cells. Once MIDD is diagnosed, assessment should not stop with glucose and hearing. Cardiac screening should include an electrocardiogram and echocardiography to look for conduction disease or cardiomyopathy. Renal assessment should include renal function and measurement of albuminuria. The patient should also undergo ophthalmological assessment for retinal or macular disease and formal audiological assessment to measure the severity and progression of hearing loss. Now let us move to treatment. The diabetes should be approached as insulin-deficient mitochondrial diabetes rather than automatically managed as conventional type 2 diabetes. Metformin is generally avoided where possible or used only with careful clinical judgment because the underlying disorder already impairs mitochondrial energy metabolism. Metformin partially inhibits mitochondrial complex 1. This can increase reliance on anaerobic metabolism, increase lactate generation, and reduce hepatic clearance of lactate. In a patient with mitochondrial dysfunction, this creates additional concern about lactic acidosis. MRCP trap, the concern is not simply that metformin is ineffective. The concern is that its mitochondrial effects may add to an existing impairment in oxidative metabolism. Sulfonylureas may be useful during the earlier stages of the disease, while the patient still has enough functioning beta cells to release insulin. Their mechanism is particularly relevant here. Sulfonylureas close the K-ATP channel directly. They therefore bypass the defective ATP signal and stimulate membrane depolarization, calcium influx, and insulin secretion. However, sulfonylureas can only release insulin that the beta cells are still capable of producing. As beta cell function declines, there is progressively less insulin available for release. At that stage, insulin therapy becomes necessary. This gives us a useful mechanism-based treatment sequence. Early in the disease, direct closure of the K-ATP channel may partially overcome the impaired ATP signal. Later, when beta cell reserve is significantly reduced, exogenous insulin is required. Hearing loss should be managed with audiological support. Hearing aids may be helpful, while cochlear implantation may be considered in selected patients with severe hearing impairment. Long-term care should also include surveillance and treatment of cardiac, renal, ocular, muscular, and gastrointestinal complications. If you remember one thing, remember this. In a non-obese patient with diabetes and progressive sensorineural deafness, always ask about similar illness in the mother and maternal relatives. Recognizing the mitochondrial pattern changes the diagnosis, the genetic counseling, the choice of diabetes treatment, and the screening required for other organ involvement. Quick recall. A non-obese 38-year-old patient has diabetes, progressive bilateral sensorineural hearing loss, and a mother with the same combination. Blood testing for the M.32438A to G mutation is negative. What is the next diagnostic consideration and why? The answer is to consider testing urine epithelial cells, because the mutant mitochondrial load may decline in blood leukocytes with age, while urine epithelial cells may retain a higher diagnostic yield. A patient with MIDD initially responds to a sulfonylurea, but later develops worsening hyperglycemia despite increasing doses. Why did the sulfonylurea help initially, and why is insulin now required? The answer is that the sulfonylurea initially closed the K-ATP channels directly and bypassed the defective ATP signal, allowing the remaining beta cells to release insulin. As beta cell function declined, insufficient endogenous insulin remained to be released, so exogenous insulin became necessary. Do subscribe to the channel for further videos.